Let's get started with today's clinical topic. And our returning champion is Dr. Kevin Suzuki. He received his dental degree from Nova Southeastern and his periodontal specialty training from Temple University. He practiced periodontics and implant dentistry at Puget Sound Perio in the Seattle area. He's a diplomat of the American Board of Periodontology, as well as the ICOI, and he's a faculty member of the Resnick Implant Institute. I'm going to turn this over to you, Dr. Suzuki, to discuss a topic that is very important to restorative dentistry and a key determinant on whether or not we can save a tooth. The why of crown lengthening. It's all yours, Kevin.
Great. Thank you very much. I appreciate the opportunity, and thank you so much to Glidewell for being invited back here today. It's my privilege to be able to present material to you about the why of crown lengthening. And one second as we get our slides up here. So again, thank you to Glidewell. Thank you very much for the opportunity to come back. I think it's my fifth or sixth time speaking for you. Very briefly, I do need to read, speaking of all the legal discussions this morning, my disclaimers. The information presented at this program represents personal opinion. Reasonable efforts have been taken intending for educational subject matter to be presented in a balanced, unbiased fashion and in compliance with regulatory requirements. However, each program attendee or clinician should always use your own personal and professional judgment when considering further application of this information, particularly as it may relate to patient diagnostic or treatment decisions, including, without limitation, any FDA-approved uses or off-label uses. So jumping right into a case here, we're just going to show you a typical example of a patient that I'll often receive a referral for. You can see here it's a tooth number 12 that's had a previous restoration. There were some restorative defects and some margin integrity issues. It was referred to me to replace, their general dentist was going to replace the crown, and they needed some additional restorative ferrule or restorative tooth structure to work with so they could also gain access to the defect. And they also wanted some more restorative structure for retention. And so it was referred to us for a crown lengthening. Now, typically, we like to try to have these cases provisionalized before they come to us, if possible. That often makes the surgeon's life a little bit easier, but I realize that's not always practical. What you can see here in the right side is what it looks like with the restoration removed. You can see the radiographic assessment there. There's been quite a bit of work that's been completed for this tooth. And towards the end of the presentation, I'll show you some examples of determining restorative value and prognosis of a tooth based on the amount of work and compromise that exists in that clinical situation. So this is what an example of a typical surgery start might look like. You can see some incisions here. I'll show you a little bit more detail on incision design coming up in one of the cases. We can perform what are called sulcular incisions or submarginal incisions. Think about when we're doing crown lengthening, what we're often implementing is the removal of both soft and hard tissue for the purposes of a more apical position of that tissue so that you have more access to the restorative tooth structure. So here we see an example of an envelope flap on the buccal, but it's also placed on the palatal. There's also been some excision of an epithelial collar there of about 1 millimeter. You can see we've actually mirrored that in what we call a cross-hatching design, and we won't get into all kinds of incisions today, but you can see that there is definitely an intentional incision design here to remove a collar of epithelium. Now, that's important to also understand that you need to have an appropriate amount of keratinized tissue of at least 2 to 3 millimeters left after the incision and the tissue is excised. And so that's really important for longevity of periodontal health. So here's our incision design, buccal and palatal. We extended 1 to 2 teeth mesial and distal. Then you see an example here of our full thickness flap reflection to gain access to that underlying osseous architecture. And what we want to do is have the purposes for access and visibility so that osseous recontouring or ostectomy and osteoplasty can be performed. So you can see the difference between the right and left side here, where some of that hard tissue has been removed, more of the tooth structure is exposed. And you'll notice we're not just implementing changes to the bone immediately at the tooth in question, we're also blending it with the adjacent teeth. And so it's really important to understand, even if you're just treating a single tooth with crown lengthening, we're actually treating technically 3 teeth minimum because the adjacent teeth are also involved in some way. This is showing an example after the flap has been apically positioned and sutured back, and then the provisional restoration is placed. This area is allowed to heal typically for at least about 6 weeks, sometimes a little longer in highly aesthetic situations. and then the dentist is afforded the opportunity to perform the restoration. Now, typically I refer these cases back to a referring partner because I'm not the one doing the restorative work. And I think that's actually a much nicer result there, as you can see, compared to the original restoration that was quite short. So if we look at the previous radiograph, we look at the post-operative radiograph immediately after on the day of surgery with the provisional still in place, you can see some very definitive changes in the osseous architecture and the level of bone there. In addition to that, if you look at the preoperative clinical and the post-operative clinical view, you can see also cosmetically there's been a significant improvement. And of course, they have more restorative tooth structure to work with to place a more properly contoured restoration. So this is just an example of a typical crown lengthening case, again, that surgeons often see. And you can see the smile line here. Now, there's other issues going on with what we call a vertical maxillary excess. This is not an oral surgery lecture today, but there's definitely procedures to go ahead and address that really significant height of that osseous architecture that you're seeing when he smiles with that high smile line. So there's just an example of kind of initially dipping into crown lengthening here. We look at the topics I'm going to try to assess here for the next about 20-25 minutes. We'll look at the indications for crown lengthening. No lecture about this topic is complete without discussing the brief aspects of biologic width, talk about some of the limitations of the technique. I'm going to talk briefly about the gingivectomy versus osseous surgery or osseous architecture remodeling. We'll show you the surgical techniques, very briefly some of the instruments that can be used. I'll show you a couple of clinical cases and then the discussion of when might be appropriate to refer versus for those of you that are doing surgery in your office or maybe thinking about starting to do crown lengthening surgery in your office. So if we define crown lengthening and what the actual objective would be, really it's to expose adequate clinical crown for the restoration of a tooth. Sometimes it's also implemented for aesthetic purposes. And so essentially what we're doing is apically positioning a flap by removing hard tissue or by conducting osseous recontouring. So when you see the bottom of the slide here, there's really two types of aspects that we think about when implementing crown lengthening. One of the most common that I think most clinicians see is functional crown lengthening. And you can see that picture there where those teeth are fractured. There's hardly any restorative tooth structure left available. So you know that you're not going to have an appropriate restorative ferrule to be able to place restorations or prepare these teeth. So from a strictly functional aspect, we try to gain more tooth structure and more access to be able to have that restorative ferrule, that retention for the restorations. And then the aesthetic aspects, the second situation as you're seeing down here on the bottom of the slide. Now that's a specific situation where this was a younger gentleman. He was about 18, 19. He had suffered from a condition called altered passive eruption where not all the teeth had been completely erupted out of the periodontium. You can see there's also some apical positioning of those soft tissue margins. And so aesthetically, we don't have really those ideal or aesthetic proportions of the faces of the teeth or the clinical crowns, if you will. And so that sometimes can be a chief complaint of many patients that come in that are looking to alter their smile. And so again, functional versus aesthetic, and sometimes it can be an implementation of both objectives. And so the why behind crown lengthening, couldn't discuss this without, of course, access to tooth structure. When we think about restorative ferrule and what we learned about in our lectures in dental school, really what you need is an appropriate amount of tooth structure for strength, for resistance and retention form. We need to make sure you have enough tooth that can actually accept the crown material, the crown margin, so you can have adequate bulk and design of the restoration. And the reason that's important is you want to have enough tooth to support the restoration while still having enough to resist the issues of fracturing or having structural compromise or failure. And so by having an appropriate restorative ferrule of at least 2 millimeters is what I was taught in dental school. Some programs teach more than that. You can avoid or minimize the incidence of recurrent decay, tooth fracture, and marginal issues. And of course, also the concept of biologic width. And this is sometimes, I think, overlooked occasionally when I work with some of my restorative partners that are very early on in the learning curve. If you're anything like my program, we had a very brief lecture on biologic width. They talked to us about in dental school for maybe just a couple of minutes, and it was a single test question. So, that was quite a few years ago. But the idea is that the periodontium has this dimension of the connective tissue attachment around a natural tooth, also the junctional epithelium that we learned about histologically around a tooth, and then also there's a depth of a gingival crevice. Histologically they say it's at least 1 millimeter, but in many cases it's often more than that. And so we take these different proportions of these biologic dimensions here of the connective tissue, the junctional epithelium, and the crevice. And on average, it's about a value of 3 millimeters that we need to respect for this biologic width principle. So what that means is if you're preparing a crown and you have a finish line, such as a chamfer or even a feather edge, you need to have a distance of at least 3 millimeters apical from that restorative margin to the crest of the bone. If you don't respect that minimum dimension, problems can ensue. And this is based on the original work of Professor Anthony Gargiulo, originally out of Chicago. I had the privilege to be able to actually have Dr. Gargiulo come to our grad perio program when I was a second-year resident and tell us all about biologic width. The interesting thing that he mentioned was that he'd never intended for this to be dogma or people to think about it in this way. He really was trying to take an average of this dimension that should be respected. And what he noticed in his research was that it actually was a range among people that could be as much as 4, 5, even 6 millimeters for some individuals. And so this is what the textbooks typically will quote. And this is what we often commonly have to respect from a functional standpoint in dentistry. But understand that occasionally you can have outliers that 3 millimeters may not be enough. And what that can look like, I'll show you in just a moment here in one of the next couple of slides. So if we look clinically at a radiograph like this, you can see a hint of some radiographic decay or demineralization here. Typically, I learned in radiology that when you see a radiographic lesion like this, clinically in the mouth, it ends up being usually about 30 to 60% larger once you excavate it. So I'm just trying to anticipate here on the x-ray what that might look like once we excavate this area. In the green there, I'm trying to kind of project what a crown preparation may look like or what some type of a prep will be after you excavate this caries lesion on this tooth. And so we know with our restorative margin and the restorative ferrule, we need to have at least that 2 millimeters of ferrule there in blue. We also need to have at least a minimum of that 3 millimeters of biologic width in that orange color. And so once you've had your tooth prepared, you want to think about the fact that you need at least 5 millimeters of tooth structure from the top of your crown prep to the crestal bone level. And so I think this picture can be a nice illustration of how those dimensions are calculated. So again, 3 millimeters from the restorative margin to the bone, and don't forget the initial 2 millimeters of restorative ferrule. So if you're a clinician who's also doing surgery and restorations in your office, you have the advantage to be able to excavate, prepare the tooth, and also temporize it at the day of or even before surgery in your office. And so again, these are the dimensions of the biologic width plus the restorative ferrule. Now, as promised, the why of biologic width invasion and the why of crown lengthening. If we don't respect that dimension, these are some of the problems that can ensue. And I often get referrals like these to my office for patients that in hindsight maybe would have been better off having crown lengthening first, or occasionally maybe we have a situation where the clinician did not anticipate that crown lengthening was needed. And so some of the consequences can look like edematous changes like you see in this photo, or erythematous changes and swelling of the margin, bleeding, and oftentimes they'll notice discomfort, some type of pain. Usually it's not acute, very severe pain, but they often describe it as kind of a low-grade kind of chronic pain or even a burn. I've had one patient even describe it to me as kind of a metallic taste or some kind of unpleasant taste sensation. And so sometimes what you'll see is this localized gingival overgrowth with bleeding and redness, and we might misperceive this as gingivitis, but it can be associated because of a restorative margin impinging on that biologic dimension. And so what can happen over time is that it can result, of course, in this chronic inflammatory issue. And we know, of course, with periodontal disease, when you have chronic inflammation in the body, we have all these inflammatory mediators that the body's producing, and it's going to attempt to break down whatever is insulting or causing that irritation. And so essentially what the body is doing with this biologic width invasion and these inflammatory changes is causing damage. And the body's really attempting to break down this foreign material that it doesn't perceive as being healthy. And so it can result in unpredictable attachment loss at various points around that restorative margin. And as a consequence of that, we can often develop these deeper anaerobic periodontal pockets, which can turn into infected pathologic pockets or localized periodontitis. We'll see unpredictable alveolar bone loss as a result as well, where you get this changes on the radiograph. And as mentioned before, it can be quite painful for some patients, not all, but many patients will report some type of unusual sensation, or they're aware of it or hyper aware, or it's uncomfortable. And so these are some of the clinical hallmark signs of biologic width invasion and the reason why crown lengthening is so important. As mentioned as well, a couple of other things about considering patients that may or may not need crown lengthening. You have to understand that there's very significant changes when these procedures are performed. In this lower left picture here, this is a patient that had to have crown lengthening on several teeth. And so eventually, before they're restored, what you'll notice is there's quite a bit of physiologic appearance and change to the periodontium. So even though it's pink and healthy, there's quite a bit of root surface that's exposed. And so aesthetically, because this is a resective or subtractive procedure, what we're doing is removing hard tissue and soft tissue. So the drape of that tissue around the teeth will be quite a bit different than what the patient was used to before. And so it's always important to have a discussion with the patient ahead of time about what the expectations are if they're undergoing crown lengthening or plan for it. So often in our practice, we'll show them before and after pictures of typical cases where other patients have had crown lengthening and what the prosthetic and restorative result looks like afterwards. You also have to look at the prosthetic value of the tooth. As I mentioned very early on, is it restorable? We'll often get referrals like this for patients that are sent to our office where a clinician asks us to perform crown lengthening on this. Well, as you might imagine, with this severe decay and this compromise of this tooth, you can see the furcations involved. We would have to remove so much bone around this tooth just to try and get some type of compromised restoration that it's really not worth it. Keep in mind, as mentioned before, also that you're removing bone and soft tissue around the adjacent teeth. So sometimes crown lengthening can be so damaged to the adjacent teeth that it's also not worth it from a aesthetic or functional standpoint. Will you be opening up a furcation in a tooth after crown lengthening is finished? And if so, how extensive will that furcation involvement be? These are things that play into not just the prosthetic value, but also the periodontal prognosis. What is the crown to root ratio going to be after the hard tissue and soft tissue is removed? And so sometimes you can have situations where we remove so much tissue as well that the mobility of the tooth is increased significantly and it's permanent and it may not resolve itself. And so that can also ensue with other problems with secondary occlusal trauma and patient discomfort. So the periodontal prognosis is extremely important as well. And then timing is a consideration. Typically, when patients come in for a consult, they're not quite sure what this looks like. Typically, we'll ask the restorative dentist to prepare and provisionalize the tooth first. Then we can perform the crown lengthening surgery, and then there's a minimum healing period of at least 6 weeks, sometimes up to 8 or 10 if it's a highly aesthetic case. So it's important to have the patient understand they're going to be in a provisional crown for a period of time. If they're undergoing the surgery, they're going to have to be careful. It's going to be explained to them from a timing standpoint what the expectations are. And so here's a couple of other examples here on the lower right. You're seeing where prosthetic value, periodontal prognosis should be considered. This third picture there where you see the third from the left, you can see the tooth that has a very poor crown to root ratio with an extremely large crown. This is very early on in my career. I did a crown lengthening for this patient, and in hindsight, I wish that I hadn't. I wish I had talked to them about the idea of extracting the tooth, performing an implant, because that tooth had a class 3 mobility. He was back in my office every other week in discomfort. He had sensitivity to the adjacent teeth. You can see I was a little too zealous about trying to keep this tooth and saying at all costs, let's remove the bone and try and make it longer just to keep it. So that can ask for problems long-term if the prognosis and the restorative value aren't considered. So we'll talk very briefly about gingivectomy versus osseous hard tissue or crown lengthening procedures. When we think about a gingivectomy, it's important to understand that what you're really doing is just excising soft tissue. So any kind of excessive overgrown gum tissue or gingiva is cut with a scalpel or a laser, depending on what type of instruments you like to implement in your office. But it's important to understand there's absolutely no bone recontouring or no bony reduction. The second you remove bone, it actually becomes a crown lengthening, and that's a hard tissue surgery. So gingivectomies are typically indicated for pseudo pockets or supracrestal bony pockets, periodontal pockets. And as I mentioned very early on in one of my other cases, you also need to calculate what is the adequate keratinized tissue that you have before and after surgery. So if you're excising gingiva, a collar of at least 2, 3, 4 millimeters, how much keratinized tissue will be left after you excise that tissue? Because you need to have at minimum, according to most periodontal dogma or literature, 2 millimeters of keratinized attached tissue around teeth, and probably even more so around implants, for healthy periodontium, healthy plaque control and comfort, and directing biofilm away from the gingival crevice. So always calculate the keratinized tissue pre and post-op. So with gingivectomies, this is actually the original article when it was published back in 1956 by Glickman. But the idea is, again, that you're excising soft tissue or pseudo pockets. You can see, according to one of these other papers from Goldman's study, they actually published a technique of holding the scalpel at a 45-degree angle or an external bevel incision, as you're seeing in some of these diagrams on the right side of the picture here. So really what we're doing is excising that excess soft tissue. You can see there's no bone adjusted at all. And so we're taking into account how deep the pocket is before and after. And again, how robust the keratinized tissue is before and after. So in that initially published case report on the lower left, you can see a before and after there where, again, an external bevel incision was used, only soft tissue was removed. Clinically, there is a significant difference in most of those teeth where you can see more of the clinical crown exposed. And if everything is calculated appropriately and there's still an appropriate biologic width that's respected, then there's going to be a permanent change there. Now, occasionally, if they have really prominent bony architecture or the biologic width maybe is one of those individuals that's much smaller in that outlier, then sometimes the gingiva can actually grow back if it's not appropriately calculated. So again, gingivectomy is really only for pseudo pockets or supracrestal pockets when you're removing soft tissue collars. For osseous resective surgery, and now this is a broad category of really bony reduction surgery or resective surgery, this is what crown lengthening pertains to. This also pertains to periodontal pocket reduction, or what we call osseous pocket reduction surgery. So the idea is performing an incision like I showed you in our first case. You can excise some of the soft tissue. We'll then gain access to the underlying bony architecture and the root surfaces of teeth. Now, if it were periodontal surgery, it would allow you to remove any etiology or calculus causing pocketing. There's then a physiologic recontouring of that underlying osseous architecture, and this can be done through surgical burrs, hand instruments, bone files, but you want to establish a physiologic architecture similar to, if you think of the analogy of dental school when we had to festoon denture wax on denture teeth around stone models. And so you want to redevelop that physiologic confluent bony architecture, what they call a positive bony architecture, meaning there's no significant concavities interproximally between teeth. And so once we perform that hard tissue resection there, we've recontoured everything, that tissue will be placed back in an apical position here. And so you're always going to have longer appearing teeth from the dimension of the CEJ or even the root surface to the incisal edge or the occlusal table. So here's a clinical example here of a patient that had a fractured tooth. You see on the upper left. If you look at the lower left, you can see the radiograph. And we do know that the patient has a very long root. So the crown to root ratio, even if we remove several millimeters of bone, will still be quite favorable. We also look at that adjacent molar on the right side of the tooth there, where the furcation is quite a bit apical. And so we can be assured that if we remove several millimeters of tooth here, we're not going to create a significant furcation involvement on the adjacent tooth. So this is just my line of thinking when I perform these types of surgeries. So to give you an example here, and I hope the video comes out okay with the transmission through Zoom, this is showing our initial incision. We'll typically use number 15 or number 12 blade. You can see here we're starting with a sulcular incision or an internal crestal incision, as some providers call it. Now, some providers will only perform these crestal incisions or sulcular incisions, and that would be sufficient for crown lengthening. The other thing you can see is that the keratinized tissue on the adjacent tooth here is a little bit thin, and so there's not a lot of keratinized tissue that would be left if we excise that collar of epithelium. And so what we're doing here is performing an envelope flap first. Then I'm going back and I am excising a small 1 to 1.5 millimeter epithelial collar. This is often optional for some clinicians. And notice I'm only doing it in this particular case around the tooth in question. I'm not excising that keratinized tissue around that adjacent tooth with recession. So this is just an example here of both a sulcular incision and an internal crestal incision. And for all these video purposes, I'm only showing the buccal just because that's the best video that I could achieve. And so again, this is our incision showing right here. We perform what's called an envelope flap. So we're going to extend at least 1 to 2 teeth mesial and distal. Once we have a clean incision that we've redrawn or recut or reincised, if you will, several times to make sure you separate all the fibers, we're going to go for flap reflection. So here we can use a combination of various surgical instruments. You can see the mult curette or the 2-4 mult is being used here. It looks like almost a spoon excavator with a much larger surface. There's a couple of different sides there. We're using it in a pushing or twisting motion. Again, it's full thickness flap reflection, so we're trying to remove all of the soft tissue tags, all of the periosteum off of the underlying bone, so we have better access. There's also an instrument you can see here called an Orban knife, which some periodontists or surgeons like to use. We're not going to show all of those. We'll then perform what we call tissue degranulation. And so there is often tissue tags interproximally. There's cold tissue. That collar of tissue that we originally formed an incision to remove. Now this is the step where we'll remove all these tags interproximally, circumferentially around all teeth involved in the surgical field. If you were doing periodontal pocket reduction surgery, many of these areas would be granulation tissue that you'd want to remove as well. And then you have better access for the underlying root surface debridement. So this can be done with surgical curettes, even scalers, Gracies, things that we're typically comfortable with from scaling and root planing. You do want to be careful not to gouge the root surfaces here when you do this, but you do want a very clean reflection with all bones showing on all root surface, no tissue tags. And this brings me to my point about when we actually do the hard tissue remodeling, we're performing what's called osseous recontouring. And so again, as I mentioned earlier, really our goal is to achieve what we call positive architecture in this diagram here. If you compare top to bottom, what that essentially means is it's ideal to have no concavities or negative architecture interproximally between teeth. That's important because if you have negative architecture, such as you see on the bottom picture, that can lead to periodontal pockets or anaerobic crevices that develop there. So we want to avoid the negative or what we call reverse architecture. So positive bony architecture, convex bone surfaces in between teeth. So that's really important. So for example, if we're performing this crown lengthening or osseous recontouring on a clinical situation like this on the lower left, you would want to gradualize or have a blending or smoothing of that osseous architecture that's more gradual like this on the middle picture there. So again, just some principles of osseous recontouring. And you notice I was showing you because I was preparing you for this clinical video here. We're showing various surgical length burrs. This is a number 4, a 6, or a number round surgical carbide burr. You can see we're using very deliberate, very small intentional paintbrush strokes. We're creating that positive bony architecture with no ledges, no sharp angles. We're trying to blend that physiologic architecture just like festooning denture wax in dental school, as I mentioned a little bit earlier. There's also various other surgical burrs you can use with round diamonds. There are end cutting burrs. You can see that cylinder on the left side of the picture there. But again, just demonstrating here some of the principles for how we'll recontour and form that physiologic bony architecture while migrating all that bone and architecture apically so that we can have more exposure of a clinical crown. So again, osseous recontouring here, we're performing ostectomy, which is removal of supporting bone around teeth, and osteoplasty, which is blending of the bone that's not supporting tooth periodontium. So that's the principle there. This is now showing some additional osseous recontouring with hand instrumentation. Clinicians will often do more subtle and refined bony reduction with interproximal bone files like you see here. There are a couple different types of files that are sold, such as the Schluger. You can see it's a much larger file that has very aggressive cutting. In this particular video here, I'm showing what you see on the lower left there. We call the Sugarman or interproximal periodontal file for much more subtle reduction or refinement. You do have to be very careful not to saw these instruments against the tooth surfaces. You can definitely gouge and remove dentin and cementum if you're too vigorous or you're not paying attention to where the bevels are on these instruments. So you can see we use it in a kind of a sawing motion at multiple angles to very subtly reduce the crestal bone interproximity between the teeth. We're also removing bone spicules off of the root surfaces very carefully with this technique. So I'm just going to scrub through there. Again, we're doing it both from the buccal and the lingual. Remember, you're not just treating the tooth in question, in this case the fractured tooth, but we're also recontouring bone on the adjacent tooth on either side. Now we're going to progress to our next hand instrumentation technique here. This is what's called a back action chisel and hoe, or they call it a TGSK curette. You can see it's used in very subtle pulling, and there's also a sharp chisel straight edge for pushing motions. Now, this is typically done after most of the gross bony reduction is completed to remove and refine any additional bony ledges, to make sure that the architecture is confluent, to remove any bony spicules on the teeth, whether adjacent or the fractured tooth in question. The nice thing about this is it's much less aggressive, and so you can be more refined. When I often teach my hands-on courses, I make our attendees learn to do it this way first before they are even allowed to use hand pieces. Because remember, when you cut away bone, it's not the same as cutting a class 1 or class 2 prep on enamel of a tooth. The bone actually melts away like butter very quickly, and you can find yourself in trouble if you remove too much bone too aggressively within the first couple of seconds of a crown lengthening surgery if it's the first time you've ever done it before. Ask me how I know. So what you're seeing again is this hand instrumentation with that TGSK. And so here's an example before and after from left to right, both pre and post osseous recontouring. And you can see there's definitely a lot more access on the right side for more changing and refining of that restorative margin. So they can definitely apically position that restorative ferrule in a more apical position. Okay, so that's typically what it looks like before and after. When we're finished, we will apically reposition and suture the flap into that new position. And as I mentioned before, again, the adjacent teeth are involved. So remember that there is going to be some exposure of some of the adjacent teeth that you need to discuss with the patient ahead of time, often in cases like this. So what you can see here is that molar tooth also had some root exposure because we had to remove so much tooth structure to get to the defect on this particular tooth. So oftentimes clinicians may have to anticipate whether or not discussion of a new restoration on adjacent teeth could be pertinent to this clinical situation. And then this is an optional step. Some surgeons are really in favor of, some surgeons are not, but it's called a periodontal dressing. I won't spend a lot of time on it, but the idea is you can place some type of a barrier or packing in a site to protect it. I'm just going to show as it's kind of extruded and then placed either with an auto mix gun or with finger pressure and Vaseline. The idea is there's these mixable and also auto light cured types of dressings that can be placed to protect the site while the patient's healing. So again, it is optional. We're not going to spend a lot of time on this just to make sure I can get through all the material, but it can be placed for up to a week or two afterwards to help with the patient in terms of comfort and preventing food from getting in there. So this is the clinical result from this situation. Remember, at first it was an extremely short restorative ferrule. There wasn't much clinical tooth showing at all. Now we have a lot more robust tooth structure to work with. And this is at least 6 weeks after the patient's had a chance to heal. Now you can appropriately prepare that with a much larger restorative ferrule and a better proportion or ratio. So typically after this type of surgery, there's a postoperative follow-up within 1 to 2 weeks where the sutures are removed if they're not resorbing. If there's a dressing place, that's often removed. You can see on the right side there what a typical armamentarium may look like for a 10 to 15 minute postoperative appointment to remove sutures and counsel the patient on plaque control. And then they'll need at least 6 to 8 weeks of healing from the original surgery for that tissue to really mature, remodel, and stabilize. So that gingival margin can continue to change even up to 8 weeks sometimes after a crown lengthening surgery. So for those highly aesthetic cases, waiting longer is often better before final preparation and final restoration. And as mentioned previously, it's always best if you can adjust and excavate and prepare the tooth ahead of time before surgery, but there may be a need as well after the surgery to revise your preparation and reprovisionalize again, maybe even give the tissue some additional time to heal and remodel before moving on to your final impression. So from a postoperative standpoint, from patient expectations, here's a couple of things that I'd made mistakes on in the past that I wish I'd explained better, knowing now with the experience I've had for doing this for about 15 years. Always inform the patients that what we call embrasures, or they call black triangles, are going to be larger in that area, at least while they're healing, and will be slightly altered after it's restored. I also inform the patients and show them before and after pictures. The tooth is going to look longer. So what that means is, of course, you have more clinical crown that's exposed. You have more anatomic crown that's showing. And so the patient is going to see more, and so they need to be prepared for the fact that there may be an asymmetry, especially if it's on one side of the smile line and the other side is not addressed. While they're healing, there's often an increase temporarily in temperature sensitivity, which usually resolves once it's restored. They do need to keep very meticulous hygiene and be counseled on that during their healing time. And of course, as you might expect with surgery, I do tell them ahead of time, and I use the word pain. I know sometimes with selling or trying to convince patients to undergo treatment, that's not always the best word to use, and it's not easy to convince them, but I'm very objective about the fact that it is a more involved procedure. When you're removing bone, there can be postoperative pain afterwards, and we have ways to help them manage it. Now, in looking back, I've really enjoyed working with Glidewell quite a bit and doing these educational seminars, but to be honest, somebody even much more experienced than myself has really published a great article on the Glidewell website. Historically, Danny Melker, he's a really respected clinician that does surgery and restorative work. And he had published this really great article showing not just hard and soft tissue management and crown lengthening, but also what to do in terms of anatomically altering teeth. And so he really had these great principles of anatomic crowns where he would prepare the teeth also at the time of the hard tissue surgery to facilitate better crown preparation, better soft tissue contours, especially for situations where you have these exposed furcations involved. And I think he had these really beautiful pictures in this publication, again, through the Glidewell Education website, showing these before and after really nice examples of what you can do with both hard soft tissue and restorative contours with physiologic crowns. So I think they're going to put that in the chat and make that available for you. A couple of things in the last few minutes I have from an aesthetic standpoint. Think about the fact that when you're doing aesthetic crown lengthening, it can often be done for situations such as gingival enlargement or medication-related overgrowth. If there's passive eruption, I mentioned a case like that. Short clinical crowns that may not have a functional issue with restorations, but from a cosmetic standpoint, may need to be changed or improved. I mentioned situations of vertical maxillary excess very early on, or if there's a short upper lip and we need to change the proportions of these teeth. So these can be some indications for aesthetic crown lengthening or aesthetic applications here, or if there's asymmetries like this picture on the lower left. So here's just some other examples here. This is a before and after case that I completed using the same principles we just talked about for aesthetic crown lengthening. This was a young man in high school. He was, I think, 19, and he was a senior, and he was trying to get everything taken care of before he went off to college. He had had this procedure completed about 2 months before he was going to prom, and he didn't have a prom date. And so after he completed the procedure, I think it was like a couple weeks before, he came back at his post-operative visit and he told me he'd never had so many girls come up and ask him to go to prom with them, or it has as much attention after he'd started smiling and being a lot more confident. So we can see that these aesthetic applications can be quite life-changing and can be really significant, not just from a functional standpoint. Here's one case where I'm showing aesthetic and functional benefit where there's some previous restoration that had some marginal decay that needed to be restored, but there was also some compromise down close to the bone. So you can see the restorations were removed. There was some crown lengthening that was completed here for a functional standpoint, but also cosmetically we had to take into account that there were some gingival asymmetries. And so again, just going through this very briefly, you can see from a pre and post-operative standpoint, we tried to get the margins a little bit better and a little bit closer to symmetrical in the anterior here. And then also, of course, from a functional standpoint, it's extremely important to address the restorative decay and have better access there. So that's an example of both functional and cosmetic crown lengthening. Now, a lot of times for clinicians that are very early on in their learning curve, if they're trying to do surgery or trying to learn about it, it can be really helpful to have something called a surgical reduction guide. When you get these very large cosmetic cases, it can be really helpful to work with a lab to be able to help provide some guidance after a diagnostic wax up. And so this was a really nice article I found in the last couple of years produced in the Journal of the American Dental Association, just showing some indications for both a surgical reduction of soft tissue, and then it turns into a surgical reduction guide for hard tissue based on ideal wax up. So planning is extremely important on what you want the final result to look like. So again, this is just one example you can find free on the JADA or the American Dental Association website for planning guides. I'm just going to show you a couple of clinical challenges. As I'd mentioned before, you have to look at the restorative prognosis and the diagnostic value or the prognostic value of the tooth, if you will. So if you have situations like this where it's extremely fractured or there's really severe apical decay, these may not be the types of teeth that you want to do crown lengthening on, again, because the fractures are so deep, there's not enough tooth left to reasonably work with, and the amount of hard tissue you'd have to remove on adjacent teeth is just too severe. Here's another example of really severe decay. Again, you'd have to remove too much bone to perform crown lengthening here, and it would compromise the adjacent teeth. Also, from a cosmetic standpoint, on that far left side there, my father, Dr. John Suzuki, who teaches and publishes a lot, that's one of his cases from the VA hospital. In an anterior case like that, with a patient with a high smile line, you have a fractured tooth there, you'd have to remove so much bone that it's going to look really unpleasant or uncosmetic or unesthetic. You have to look at the remaining periodontium. Sometimes if they're already periodontally compromised, if you have to remove more bone, it may not be worthwhile, and the prognostic value, again, of the tooth is not worth it. You also want to look at root length and root form. If you have these really tapered or blunted roots and you remove hard tissue from those, imagine how mobile those teeth will be afterwards or whether or not it's even worth keeping. And then root proximity can be a significant issue. It's every surgeon's nightmare if you go to perform crown lengthening, you're actually cutting away tooth structure here. That can be really, really difficult and often compromise adjacent teeth in terms of endodontic issues. Never perform surgery without appropriate radiographs. You don't want to have a situation where you encounter the sinus, you perforate it. Now the patient has an oral antral communication or sinus involvement. So make sure diagnostically we're always looking at the most appropriate things. And then me being the periodontist, we'd be remiss if I didn't include, of course, taking into account where the furcations are and if you're creating a worse off furcation involvement after surgery. So make sure that you look at the value of that on the radiograph. So, and then the last slide I'm going to show you here would be when to treat in your practice if you're doing surgery versus when to refer. So if you're early on in your curve or your learning skills, you may want to consider performing crown lengthening on a single tooth. Typically, a posterior tooth where you have good access and visibility is one of the most desirable situations to start with, like a premolar or a first molar. You want to make sure it's periodontally stable. It's not significantly compromised with bone loss or furcation involvements or active pocketing. So always treat the perio disease first and stabilize it. Typically, you'd want to start with patients that have an extremely low smile line, so they're not showing a lot of gingiva or not showing any of the periodontal soft tissue drape because, we're still learning. We're just early on. We don't necessarily want people to be able to obviously see how much changes we're doing. If we get into more complex situations, these may be cases where you want to refer out of your office. So situations have a highly aesthetic demands of a patient, or they're very difficult. Maybe they have a very high smile line. Maybe they're a celebrity. We have multiple teeth that require balancing and physiologic recontouring and symmetry. That's when we start getting these really involved guides like I showed you in the ADA article. If the patient is periodontally compromised, you may want to partner with a periodontist first to control the periodontal disease and then have them perform the crown lengthening because many of these situations will already have bone loss. If it's adjacent to a dental implant, that can often be fairly intimidating to a neophyte clinician doing surgery because you do have to sometimes remove some bone or recontour bone around an implant. And then you're, of course, balancing the challenge of trying to not damage threads. Medically complex patients, such as patients on blood thinners, can be a nightmare to manage during surgery. And then what I've found is that second molars, especially mandibular second molars with a very high ascending ramus, extremely difficult. You want to book at least an hour and a half to 2 hours for these kinds of cases sometimes. So these are cases you may not want to tackle in your office if you're doing surgery. The last two slides I have to show you, if you are considering hands-on training for this, I do want to make sure that as dentists, there are courses to be available to do this all over the country, all over the world. There is a course coming up. My father, Dr. John Suzuki, is a former dean and a clinician that does a lot of education. He's teaching at the Tide Institute in Canada. You can find more about that here. It's coming up at the end of the month. And so I think there are still spots available, but this is one opportunity if you wanted to learn as a general practitioner, opportunities to perform crown lengthening or hard tissue surgery in your office. It is a hands-on course. So again, that's at the Tide Institute in Canada. And then there are other options as well. I enjoy teaching courses with Professor Gordon Christensen and my father, Dr. John Suzuki, down in Provo, Utah at Gordon's PCC Practical Clinical Courses. And you can get more information about that here as well. We do hands-on courses with pig jaws. So thank you very much for letting me share that. I do work out of an office in Seattle. This is my email. If you have questions about lecture that I couldn't answer today, I'll stick around, of course, for a few minutes. But I work at Puget Sound Periodontics in Seattle. If you're ever in the area, you want to reach out to me, if you want to come shadow sometime, we'd be happy to share with you. So thank you very much.
Well, thank you, Dr. Suzuki. That was an excellent lecture. Really a very, very practical look at crown lengthening, the why and the how. I really appreciate that. We've got some really sharp questions here for you. So I'm just going to jump right into it. What do you do in the situation where you're trying to create a furrow for restoration, but there is no attached gingiva? Do you do a separate procedure prior to crown lengthening to develop some attached tissue?
Yes, that's excellent because that means the clinician's thinking about keratinized attached tissue and the long-term implications. Sometimes it may be necessary to plan a keratinized graft or what we call a free gingival graft first. And then after that's had a chance to heal for at least 6 to 8 weeks, then performing crown lengthening. So yes, sometimes that can be a consideration. Absolutely.
Okay. And what about the situation where there's kind of a short root to start with? Is there like a minimum amount of remaining root that we have to make sure we have?
So oftentimes what we'll look is we'll calculate the clinical crown to root ratio. And so periodontists typically like to have a ratio of at least 1:1, or sometimes we'll accept a ratio of 2:1 if there's no mobility and everything else is stable. But if you start to exceed that, such as like a 3:1 crown to root ratio or 4:1, those are very unfavorable. So it really depends on crown to root ratio. So I'd say at most you're really pushing the envelope and it's a 2:1 ratio or greater. So ideally 1:1 would be the max I would endorse.
Okay. So a kind of a short root would be sometimes a contraindication to have this procedure done.
Absolutely.
Interesting question. What about orthodontic extrusion rather than this procedure?
Thanks for asking that. Yes, I didn't have time to include that because that's also an important option to understand that is available. So orthodontic extrusion, you'd have to send the patient, or if you're doing orthodontic treatment in your care, you would attach brackets. And what I found is I haven't found an orthodontist, at least in Seattle, that's willing to do limited ortho. Really, they want to ban the whole arch. They want to do everything. And so it does take months, in the order of months. Sometimes they'll say it could take up to a year where they're actually, extruding the tooth or pulling it coronally. But when you do that, a lot of times it brings the hard and soft tissue with it. So then you still have to perform crown lengthening surgery. And so there's times where I have talked to patients about that option, but what I've typically found is from a practical standpoint, most patients don't want to undergo comprehensive ortho, then still have to do surgery. Because it's just a lot for them to go through, and financially it does create a significant burden. But yes, that absolutely is very much an option that can be valuable in very highly aesthetic situations where they don't want to go through an extraction.
Great, great. Okay, and I know you're very involved with laser treatment and very experienced with that. And there's a lot that we hear about. Hey, with a laser, you can do this procedure on the same day as you do your crown prep. What are the limitations and the capabilities of laser treatment for crown lengthening?
Yeah, so typically the kind of lasers that I'm familiar with that are typically hard cutting, especially the ER YAG laser, is a hard tissue laser designed to cut. In terms of same-day treatment, yes, theoretically you could do the crown lengthening and then place the restoration on the same day. The only thing I would caution about is that, lasers don't cut quite as precisely as, surgical burrs do and surgical, hard tissue cutting instruments like we're used to. And so the thing is, you only have one chance to get it right with healing from the start if you commit to that final restoration. And if you don't wait that 6 to 8 weeks for the tissue to kind of remodel and recontour, or if we're even just a little bit off, then you're looking at a scenario where, if the patient's upset about the cosmetic result or the gingiva comes back a little too coronal, those would be the things I would caution clinicians about. So yes, in theory, you could do it all in the same day, but, I'm not a big fan of that, only because you only get one chance to heal right, and then after the fact, trying to clean up a situation can be troublesome.
Okay, but the laser treatment for crown lengthening is an established treatment. I mean, somebody mentioned that had difficulty getting payment through insurance for crown lengthening with laser. That should not be. It is an established procedure.
Well, so when you think about crown lengthening, when you're using a laser, essentially all you're doing is replacing the cutting or the way that you're implementing incising and ostectomy with a different instrument. And so from my experience, and I don't know about the legality of this, but typically, insurance carriers, once they see the term laser, they're not going to cover most things. What we found is that, if you're still accomplishing the same objectives of ostectomy and incising tissue and resecting it, you don't necessarily have to say that you used a laser. You can just say an incision was made, ostectomy was completed. You'll probably get better opportunity for reimbursement with that. You're still completing the same objectives. And yes, I think it is established and it is safe and acceptable. I don't think it's beyond the standard of care to use a laser for crown lengthening because there are specific hard tissue cutting lasers. So that's my opinion.
Got it. Yeah, just like you don't mention that you're using a Sugarman file. So why would you mention that you're using a laser?
Absolutely.
I like it. I like it. Hey, excellent lecture, Kevin. As always, you bring us really, really practical information that is going to benefit all of our practices. So we appreciate it very much. We look forward to having you back soon. And thanks everyone for joining us today. And thanks to our panel. And we will see you back next week when we'll have, as always, our business advisory panel. And our special guest speaker will be Dr. Randy Resnick, who will be continuing his series on occlusion for implant restorations, and he'll be talking about single and multiple implant crowns. So we will see you back next week at the same time. And thanks, everyone, and hope you have a great week. Take care, Kevin.